Hey, what's going on, everyone? Hope you guys are doing well. This is Dr. Delon Canterbury, CEO and founder of GeriatrX, as well as the Deprescribing Accelerator. So, hope you guys are continuing to have a phenomenal week. Life is going pretty well right now, so hope you guys are feeling the very same. So, welcome back. Hey everyone. Hey Jennifer. Appreciate you tuning in. Hey guys. Hope y'all are doing well. Appreciate you showing some love. What's going on, Mariko? Thanks for the love and for tuning in. Of course, today we're talking about the 3 best practices that pharmacists can use to start leveraging and deprescribing, but of course, helping and serving our seniors. That's the whole goal here. So good seeing you. Thanks, y'all, for coming on board. So today's going to be a little bit of a shock because we're going to be talking a good bit about fear, and we're going to talk about mindset shifting a bit here to really get into this space of serving authentically in your role. So we will dive on in. But let's first talk about some pretty easy, quick tips that you can use. Hey, what's going on? Some pretty easy tips you can use to start advocating for our seniors. And this one's pretty much a free throw. It's pretty easy. And frankly, easiest thing to start doing to get more aware, to get some of your confidence, to start building that muscle of senior care advocacy is getting used to knowing what the beers list is, right? I mentioned a little bit about this in our last episode, but the beers list, for those who don't know, was actually developed by a geriatrician in like the late 90s. And this was an attempt to create this compendium about, I don't know, 200 drugs or so of potentially inappropriate or harmful medications that can impact our seniors. Okay. So it's not like a naughty list, but it's more so just a general idea of, this should give you some pause if you are maybe doing a review on some elderly patients and you may be seeing some duplicate therapies, you may be seeing some side effects that can be managed otherwise without using, guess what, another pill to treat that. So the beers list is awesome. It's like the first thing we cover in the Deprescribing Accelerator. And it's free. It's easy. Anyone can look it up. Anyone can download it. I may have mentioned that they're supposed to drop a new edition this year. I thought it would have dropped by now, but maybe we'll see it this next quarter. But they update this list every 3 years. Okay, so the last one was 2019. So stay on the lookout. Again, I believe it was Dr. Mark Beers who made this list. And this list, again, is vetted by the American Geriatrics Society. Okay. So they are the ones who get international renowned geriatric practitioners, nurse practitioners, researchers, doctors, clinicians, of course, to basically assess and review this list of all these drugs to make sure, are we on the right track for what is considered to be potentially harmful in our seniors. So you'll find, my God, tons of examples. And why I like the beers list is, honestly, when I do my reviews, I look at this list and I always do like a control F search for any drug my patients are on to give me an idea of whether there may be any red flags I need to look out for. And they also go further and break it down by disease state. They can break it down by contraindications, right? If you have a certain health condition, it'll flag you for what may be, again, inappropriate. So if you have, say, kidney failure, right? Or if you have liver issues, okay, or maybe hypersensitivity reactions, the beers list is going to make it pretty super simple to find out what could be problematic. And they give you the rationale, they give you the evidence, they tell you exactly why there's an issue with this. And this is like easy. It's just, I download it, Control F. I look and see if there's anything missing. And don't get me wrong, it's not going to catch every single potential harmful medication. That's not the point of it. It's for you to give pause to what your loved one may be taking or your senior patients may be taking, and of course, advocate to the next level that I feel we all should be doing. So beers list is super, super easy. No, it's not a list of the top 10 ports and sour beers and lagers. I'm more of a sour beer guy. It's BEERS apostrophe. So I guess it's German. I'm not sure. But needless to say, super easy. And if you don't have it, download it or just bookmark it on your computer and make it readily accessible for you. But this is pretty dope. I mean, the beers list, again, is looking for the top potentially inappropriate medications to be looking out for in our seniors, okay? Simple, easy. And one thing I've shown benefit in this is just coaching other clinicians to talk about this, right? I mean, it's been around for 20 to 30 years. So if you're in a nursing home or you're working in these facilities, I think just having a quick little in-service talking about, hey, let's talk about these class of meds, antipsychotics, right? We know, and I preach to the cows come home, how much I hate antipsychotics in our elderly, which is often used to chemically sedate and numb them, and that's screwed up. And frankly, it's an FDA black box warning for people who suffer from dementia. So you know I'm gonna get riled up about that. But needless to say, I see Seroquel in these populations all the damn time, regardless of the FDA black box warning saying that it's inappropriate. It ends up being a continued battle that a lot of us pharmacists, especially in the consultant pharmacy space, end up having discussions on and trying to document and make sure there's some kind of gradual dose reduction. Another big one, right? Benzos. We know for sure that benzos can increase the risk of falls and confusion in people, particularly our elderly who are more sensitive as our bodies change and don't exactly clear the drugs like they used to do before, right? So if we know that's the case and you want to maybe, I don't know, reduce falls within a nursing home or within your patient or community pharmacy, and you just simply do a talk about benzos, hey, if someone is no longer taking a benzo after your intervention, then hey, you've saved a life potentially, and you've probably saved our healthcare system more money, right? So number one, easy, simple, download the beers list, check it out. Again, this is curated by the American Geriatric Society, easy to use. I do Control F to look up all the drugs my patients may be on. Search the generic name, not the brand name. It's more the generics in there anyway. All right, so that's easy. The next one, okay, in the world of deprescribing, you want to figure out what role do you want to play, right? Are you trying to be the community advocate? Are you trying to serve in your church? Are you trying to serve in your synagogues? Are you trying to serve? Where are you showing up? Where are you serving? Are you trying to do this with your own current position? Are you trying to do this at your work, at your job, in an ambulatory care setting? It can be done this way, right? But I challenge you to choose one thing that you are passionate about. One topic of deprescribing that makes you wake up like, this is dope. I'm helping someone taper off of these antipsychotics or benzos, or better yet, opioids, right? We got a huge overmedication problem as it comes to the opioid crisis, which you could probably blame Big Pharma for that. But I think Walmart and Walgreens and I think CVS all are going to be fined about $632 million for their role in the opioid epidemic, which I think dropped yesterday or 2 days ago. And I think it should be more, but here we are. But hey, that's a win. But let's talk about the elephant in the room. We still now have people that aren't getting medication-assisted therapies. We still have people who are unfortunately having to resort to the black market to get their fix, to maintain what they were hooked on, probably legally, by our healthcare system. So, say you have a passion for opioid deprescribing. We do cover that in our course, but more importantly, this is a great way to help serve your communities, because Not only is there a huge public health crisis around this, but now there is more government funding and federal grants that are going towards integrative practitioners who are looking to help people get off of opioids safely. And they're called medication assisted treatments. And you can have your very own medication assisted treatment facility. You don't have to be an MBA. You don't have to get a whole new license. I mean, maybe to, I don't know, counsel on Narcan or prescribe it. I don't know. But you can partner with a doctor or clinician or social worker or therapist and literally just create an opioid reduction program. The CDC dropped opioid guidelines in 2016. And they actually give some pretty good advice on how to consider tapering opioids. So even evidence-based, there are some strategies you can employ. So again, I'm telling you to choose one thing. I'm passionate about teaching all of you how to do all the things so you have options. But the point of our course is for you to choose one thing you're super passionate about. One of our alumni, Dr. Judy Waldman, super passionate about holistic health and wellness. What she ended up doing with her health coach passion is leveraging this and using her pharmacogenomic certification, once she learned about the power of it, to now start working with adolescents before they become geriatric and hit that storm before it becomes out of control for her communities in South Dakota. So now she's using pharmacogenomics from just one of our modules. No, we're not here teaching everyone all about PGX, but we're here teaching you that it is a tool that you can use to advocate and deprescribe. So that's her goal now. Awesome. One of our other alumni, she chose the caregiver space. She chose the nursing home space. So she now wants to train more nurses on how to become deprescribing advocates through her network within her caregiver circle. Brilliant. So now she has an ongoing workshop, and one of them, even further, is starting her very own deprescribing conference, talking about medication safety. And again, she's a nurse and a health coach. This is Miss Charlene Sparks, along with Miss Sharon Fant, who are a past alum, but they are putting the pedal to the metal and choosing one thing and sticking to it and making that their revenue stream. So you got to choose one thing. And that's really the whole goal here, is showing that there's a world of ways you can integrate yourself and advocate and, hey, serve, which is what brings me to number 3. Number 3 is just serving. Just serve. You know, we're all here training and advocating for seniors, but even so, there has to be a specific thing that you want to work on, right? I met this brilliant pharmacist who is based in Alabama, and he literally has a company devoted to teaching people how to reduce falls in ALFs, in adult daycare centers, in senior homes. And now, mind you, wasn't a part of our program, but I learned about his work just from meeting people like you who tune in today and are curious about the concept of deprescribing. And he's doing phenomenal work. He has literally led the charge on creating an aging task force for the state of Alabama as a pharmacist. And all he's doing is reducing the risk of falls. That's all he's doing. Yes, there's core tenets of deprescribing there, reducing those high-risk meds that can worsen the risk of falls. But he's now putting in policies that are statewide and funded by the government of Alabama to make this the norm for care. So this stuff ain't exactly unicorns and myths. This is what people are doing as we speak. And that's why I can't not share that with you, because I'm excited about the world that this can look like once we really start unifying and leveraging our secret power as deprescribers. Okay, so serve. How do you want to serve? Are you going to show up and serve through your church or a community center or an adult daycare center, nursing homes, ALFs, LTCs, independent living communities where a lot of our seniors are? You choose. I've pretty much thrown my hat in the ring and have worked and done something in all of them in some capacity. And all of them have been beneficial for, well, not just growing what I'm doing, but showing that pharmacists are way more than just dispensers. We are literally consultants just by what we do, just by what we've learned. So we're the expert, and all I did was own it and show you that you can do the very, very same thing, okay? And I'm gonna give y'all a bonus one, all right? Bonus. You gotta acknowledge the sheer truth. And the sheer truth is this: we have an intrinsic culture to want to take medicines in this country. We have a very flawed medication mindset. We assume medications are like lifelong best friends. Like, no, they're not. You just need them for a little bit for the most of the time, and you're done with them. So we are really, really good in Western medicine at treating, but we don't know how to stop treating, if you get my point. We don't know how to deprescribe. We're not taught this. So we're taught to, again, diagnose and probably overdiagnose, and then overtreat. And then you don't even think about the repercussions of, all right, well, let's reassess in 6 to 8 months. It's just kind of up, he's on it, boom, life sentence, you're done. You know, we don't give any leeway to, all right, is it time to stop? And I mean, how many consultant pharmacists are out there who see omeprazoles and all these random proton pump inhibitors that just been on for decades, just for decades, or random Tylenols or supplements that have lost their indication, or baby aspirin, which just now is getting debunked as really being even necessary by the USPTS task force, our public health task force that makes our recommendations for these clinical decisions. So I say, as a fourth way to really, really start leveraging deprescribing and making this your baby, making this like what you are doing in your community, is to align how you want to serve, which is what we discussed in number 2, by picking one deprescribing problem that you want to tackle, and then just showing up and serving. Just showing up and serving. I don't care if it's for free. I don't care if you're volunteering. I don't care if it's paid. Just show up in a place that aligns with you and what you do. I mean, even today, I had an amazing talk with one of our applicants about her passion for holistic and wellness, right? And she's taking it a step further, which is why I really love what she's doing, by becoming, and in fact, she already is, a yoga instructor. She's already tackling a different modality to care and has a passion for deprescribing and medication management and working with seniors. And she wants to have that impact. And she's doing so by channeling different avenues, being now an integrative health coach or integrative health practitioner. And so she can use her yoga expertise as a means to deprescribe, which is exactly what we cover in our course, using acupuncture, maybe using yoga, mindfulness therapies, CBT, whatever. There's so many ways you can take it. So here she is, who already has that niche market of using yoga and stress management as a way to potentially reduce anxieties and depressions and work with those social factors that really impact your health outcomes when you are a senior, potentially in isolation, and you may not have that type of dynamic. So the choice is yours, right? Number 1, we mentioned today, leverage the beers list, make that your friend, bookmark it, download it, put it in your document somewhere, print it out, highlight what was interesting, but just get comfortable to seeing what's on the list. By this point in my game, I pretty much memorized it. Oh, okay, you're a Zumba instructor. Okay, thanks for sharing that, Christian. So boom, that's brilliant, right? Movement is medicine. I'm quoting Dr. Judy Waldman, one of our past alums. She loves to say movement is medicine. So it is. It truthfully is. And I tell you what, I did Zumba one time and that kicked my butt. Like I was dead. Like my asthma came back. I was like, I needed my inhaler, but it was a good workout because I like to dance. I didn't realize how much I like to dance at that time. But I can imagine that doing wonders. I mean, I usually recommend stuff like water aerobics for people who are, dealing with pain or chronic osteoarthritis. So I could see Zumba being even better. I mean, I don't even know that many Zumba instructor pharmacists. So that's pretty dope for you to use that and find a way to leverage, again, the medicine behind movement versus our traditional approaches to, let's throw you on an NSAID or Tylenol or up to tramadol and see what happens. And we're not even talking about genetic implications with that yet. We're just talking about, where that can take people down. And I've definitely known people to abuse tramadol just from clinical expertise, right? So I love that. I love integrative approaches to care. And I think that needs to be the standard of care. Okay. So today we gave you 3.5 to 4 tactics, tips you can use right now to start leveraging deprescribing. Number one, we talked about making the beers list really, really comfortable for you. I think you should honestly use that as a starting point. You should read it, just go through what's in it, pick a category. And once you find that category that drives a fire in you, make that your main thing you target. Make that the thing you talk about on your social media or when you give talks or maybe volunteer information while you're doing your med reviews. But make this not just a clinical tool, but a community tool. See, that's the problem. We are quick to have all these cool little tools and assessments and questionnaires, and we do it on our end, but we don't give that back to the people who see it every day. So there's a disconnect between that provider role, prescriber role, and the patient community social role, man. And I'm just bridging the gap. That's it. So number one, we talked about the beers list. Number two, we talked about picking one deprescribing topic. Again, that could be like stopping opioid use in seniors. It could be stopping falls in dementia patients. It could be reducing NSAID use in heart failure patients, like our last cohort learned about with the elder options group. Could be drugs that worsen dementia. I mean, the list goes on. The list goes on and on and on. So just choose one. Don't overwhelm yourself. Choose one if you love it, and make sure it aligns with your core beliefs as a future deprescriber. Number three, serve. Just serve. I don't care, again, if you're getting paid for it or not, but show up authentically, and whatever that issue is, speak it to the mountaintops. And then number four, as an added bonus, is changing our medication mindset, understanding that we have a culture of wanting to take a pill, and then challenge that culture and make it the norm to get off of these meds. And once we have that medication mindset altered, people are going to lean in. They're going to lean in, they're going to listen, and they're going to want to know what else you got to say. And they're going to know, how can I get my loved one off of these meds? Because you're telling me that this NSAID is not necessary. And I thought it was for all this time because, the doctor said so 30 years ago. That's what we're breaking up against, okay? So hope today was great. Hope today was helpful. Appreciate all the love and engagement for all y'all tuning in. I would love to know what you guys think. What resonated with you? What do you think was helpful? What was not helpful? What do you want to learn more about? I'm curious to know your thoughts about deprescribing, and maybe even know what challenges you may have. Have you ever deprescribed something and found someone who ended up back on that medicine like 2 months later, right? Is there a group think issue going on? Was it a reactive thing? Was it just a mistake? I don't know. I've done medrecs, and I've definitely seen meds thrown back on outside of my role with geriatrics. So just curious what y'all think, but appreciate the love. Appreciate y'all tuning in. We had a great engagement today. And, I'll see y'all next time for our next video. And we'll continue our red pill versus blue pill video series. If you're interested, please be sure to check out our application link in the comments in the description to learn more on ways you can get all the details about our program and then just see what our past alumni are saying. Christian, hey, you asked a question about some advice for P1 student pharmacists, hey man, you're just starting your journey, but it doesn't mean you can't start doing what you're supposed to do in advocating. So if you do have a true passion for this, I think you should ask your teachers what deprescribing is and how come it's not being taught in your schools. That's one thing I would do. Two, you got a lot to learn. Like P1, you're just trying to get your feet wet. You don't even know, like, you're just like learning biochem and like basic pharmacology. I think this will start being relevant a bit more in probably in P3, P4. But truthfully, I think we need to challenge what we literally start learning in school. And that is assuming that you need to be following all the damn guidelines. Because guess what? You do need to know what the guidelines are saying. And that's the point of pharmacy school. And then once you leave, you realize, oh, snap, no one follows the guidelines. Oh, the guidelines are like, they're there. So there's a little bit of level of clinical expertise you need to have under your belt to really start saying, you know, I believe we should get you off of this as a senior. But I think you could still talk to the issue at hand, which is why aren't we looking at other holistic or other alternative approaches to care? And I guarantee you, apart from the workout 30 minutes a day recommendation, we're not being taught how to think this way in our pharmacy schools. So this is a bit of a rebel type of mentality. So you can always be that person who advocates. And I'd say if you are really passionate, then you need to start talking about the problem and working with people who do and advocate this way. So those are my 2 cents. But great questions. So anyway, much love, y'all. I appreciate y'all tuning in, and have a fantastic week. I'll see y'all next time.